And today I am going to present diabetes fundamentals and inpatient glycemic care for the patient care tech. So the objectives for today is to identify some roles and responsibilities of the patient care tech in the management of diabetes, understand the best practices of management of hypo and hyperglycemia, and apply appropriate and reasonable interventions to ensure patient safety. So why are we doing this? I'm sure you guys have all heard about the inpatient glycemic control strategic goal that we had during the fiscal year 2025. Our goal set by Ascension was to improve patient glycemic control, which includes hypoglycemia and severe hyperglycemia, starting on the second calendar day of the hospital stay for all admitted patients that are greater than 1 year of age. Ascension had set the relative improvement goal of 4% improvement over that fiscal year 2025, which I'm happy to say we did meet in terms of hypo and hyperglycemia patient days. So why are we doing this? 27% of patients admitted across Ascension hospitals have diabetes. Mortality rates are significantly higher among those with uncontrolled blood sugars versus the general population. And you can see it's 2.6 times higher for those that have severe hyperglycemia while they're admitted, and 9.4 times higher for those with hypoglycemia. Inpatient glycemic control really is a multidisciplinary collaborative effort. It takes providers, nurses, patient care techs, pharmacy, dietitians, all of us in order to work together in order to manage glycemic control for patients. Diabetes is very complex with a lot of moving parts, and it just takes us all hands on deck. So today we're going to talk about why your role as a patient care tech is extremely important. The role that the patient care techs play in terms of inpatient glycemic management is important because you're the one who completes most of the finger stick blood glucose testing. You're in the room at meal times. You usually get to know the patient better than the nurse does. You have more time with the patient. And you may be able to pick up on patient changes first and notify the nurses. So understanding more about diabetes and inpatient glucose control will make you better and more prepared as a tech. So the patient is our central focus, of course. The central focus is to incorporate the patient at the center of their individualized care plan with an emphasis on empowerment, education, and self-management. Like I said earlier, diabetes is complex. Every patient that has diabetes is unique and cannot be treated the same way. I'm sure you've noticed one patient who gets 10 units of insulin, that amount of insulin doesn't even budge their blood sugar, whereas somebody else that gets that same amount can have a low blood sugar. So it's highly individual in terms of medication, nutrition that they're eating, and how physically active they are, which in the hospital they're not. So patients with diabetes should not be defined or labeled as quote unquote diabetic or non-compliant. This really just is a culture shift in how we talk to and talk about our patients that are living with diabetes. A lot of people with diabetes, when they hear the word, oh, you're diabetic, it feels like you're labeling them as their disease. And it's, for a lot of people, they don't like it. So just from a customer service standpoint, we're trying to change the culture. And also, the Ascension Event Reporting System finds that insulin is the most commonly reported medication class associated with patient harm. So we're trying to reduce and eliminate that. So what are the benefits of maintaining good blood sugar control when somebody's in the hospital? Obviously, improved quality of care. Patients are used to having their blood sugars controlled in a certain manner at home. And when they come to the hospital, they expect that we're going to do the same. And when we are not able to do that, some people think, oh, they don't know what they're doing. And we don't want that. So we want to improve our patient quality of care. They stay shorter times when they're in the hospital and their blood sugars are maintained. It is also a 200% higher cost when we don't control the blood sugar well. Controlling glucose in the hospital has a 75% decreased post-op wound infection, 46% decreased cases of sepsis, And you can read here on the slide all the improved outcomes that you get when you control the patient's blood sugar well. So let's kind of talk about the diabetes basics. First, we need to understand what are the differences of the different types of diabetes. There's basically two types of diabetes, type 1 and type 2. Type 1 diabetes is what we used to call juvenile onset. And type 2 diabetes is what we used to call adult onset, or I think a lot of times people would call it non-insulin dependent diabetes. We've changed that because the lines have grayed. A lot of people with type 2 diabetes will end up on insulin, so calling them non-insulin dependent really didn't make sense. The same is true for type 1. What we used to think only happened in childhood can happen throughout the person's entire life. So I've actually seen a patient who was 77 years old get diagnosed with type 1 diabetes, which was kind of confusing at the time because you associate type 1 diabetes with children. So type 1 diabetes is an autoimmune disease, much like Raynaud's, Sjogren's, celiac disease, where people can't have or don't tolerate gluten. What else? Juvenile or adult onset rheumatoid arthritis. Those are all autoimmune diseases. And basically what happens is the patient gets ill with a virus and their immune system attacks part of their body. And for type 1 diabetes, it's the beta cells in the pancreas that produce insulin that are destroyed. So type 1 patients do not produce any insulin. Diet, exercise, and other lifestyle changes can't reverse or prevent the onset of type 1. And they're dependent on insulin for the rest of their lives, at least until there's a cure. Type 2 diabetes is a little bit different. It's caused by insulin resistance. It's not that their bodies aren't making insulin. They are. Their body just is resistant to using that insulin to lower the blood sugar. The beta cells over time do get destroyed or deteriorate over time. And that's why we see a lot of people with type 2 diabetes also needing to take insulin injections. And so it kind of gets, the waters get muddy. And a lot of people think, well, I had type 2 and now that I'm on insulin, I've developed type 1. And that is not the case. Once you have type 1, you always have type 1. Once you have type 2, you always have type 2. It's just how you manage the disease that changes. Type 2 is a little bit more of a progressive disease in terms of how we treat it. And so, like I said earlier, a lot of people will end up on insulin. So just some reminders about type 1 diabetes. Because they don't make any insulin, they are at high risk for developing what's called diabetic ketoacidosis, or DKA. And I'm sure you guys have all heard of that before. Patients who have type 1 who are wearing insulin pumps are at extremely high risk for developing DKA. If the pump is either removed or disconnected, or they lose their sight, maybe it got sweaty and came off of their body. If they go without insulin for an hour or more, they do increase the risk of developing DKA because you've cut off the source of insulin, and they need insulin to metabolize carbohydrates. Also, if the patient eats a carbohydrate, they require a nutritional insulin dose to cover that carb or to prevent the rise in blood sugar after they eat carbohydrates. So even a patient eating a handful of crackers in the room or drinking maybe half a cup of juice, that can be the difference of 50 points in terms of their blood sugar for a type 1. Not so much the case for a type 2, but for a type 1, it really would. So if you're noticing a patient in the room is snacking a lot on things in the room, mention that to the nurse, because the nurse probably needs to call the doctor and get a snack insulin dose for that patient to allow them to snack on things but still get insulin when they do so. And just one more little caveat, those with type 1 diabetes tend to need less insulin than those with type 2. But okay, and gestational diabetes is, I don't want to call it the third form, but it kind of is diagnosed during pregnancy. It is strongly related to developing type 2 diabetes later in life. You can see the risk factors here for developing gestational diabetes are basically the same as developing type 2 diabetes. And the risks of uncontrolled gestational diabetes when a mother is pregnant, for her, she has a higher risk of preeclampsia, high blood pressure, and C-sections. And for the baby, being a larger than normal birth weight, respiratory distress, the patient can get a hypoglycemia, or the baby can. They can have jaundice. They can have fetal abnormalities. And they can also, if the blood sugar's been uncontrolled severely, they can also die at birth. So a big deal. The risk of developing type 2 diabetes is increased tenfold for these mothers if they had gestational diabetes when they were pregnant. So let's talk inpatient glycemic control. So what are the targets? This has kind of been a moving thing over the last decade. We thought we needed to get blood sugar controls really tightly controlled, but we quickly found out that's not the case. You can see here that what we're aiming to do is get blood sugars in the non-critical care units anywhere from 100 to 180. Perioperative, the same, and basically 140 to 180 for critically ill patients. The risk is that if we target a lower number than these, like if we're trying to get a near normal blood sugar, those patients can have hypoglycemia. And remember at that beginning slide, a hypoglycemia increases the risk of mortality. So what we're trying to do is get the patient somewhere that they're safe from super highs and they're safe from having hypoglycemia or lows. So monitoring is extremely important, and I feel like this is an area that patient care techs really can have a really big impact. So when somebody's NPO or on nutrition support, we really should be checking the blood sugar every 4 hours. And when they're eating meals, we're checking pre-meal and at bedtime. And sometimes we may even add in a 3 a.m. Blood sugar check for those patients that we're worried may have hypoglycemia overnight. So those are our standards here at Ascension St. John. If you come across somebody who's eating and is doing Q4 finger sticks, that's something you were going to want to probably remind the nurse about, and that way she can get that order updated. The Ascension St. John critical glucose levels are here. The high is greater than 500, the low is less than 54, and of course the lab's going to call the nurse for any blood glucose on the labs that meet this criteria. The hypoglycemia protocol will be initiated, as you guys know, for anything below 70. The stat strip glucometer that we use in the hospital will produce a result viewable on the screen from 10 to 600. Anything less than 10, I believe, don't quote me, it may either say low or it just says less than 10. I'm not 100% sure. I know what it says in Cerner is less than 10, but I think on the screen it's going to say low. And then greater than 600 is going to read high on the meter. So using the stat strip meter, it's extremely important to wear gloves. I have been through patient rooms and seen some people checking blood sugars without using gloves. You're dealing with a blood product, so it is really important to wear gloves. I have type 1 diabetes, and I can tell you blood has squirted all over my hand, and it's just better to make sure you're wearing gloves. You can't always assume that it's going to stay on a nice little clean dot. So make sure the patient's hands are clean and completely dry before you test. And if you're using alcohol to clean the fingers, make sure that it is completely bone dry before you poke the finger. If it's not, what's going to happen is the alcohol or any water that's on the patient's hand is going to dilute the blood and therefore affect the accuracy of the test. It's also important not to use dummy numbers. If you try and scan the bracelet and it doesn't scan, you can type in the patient's last name. It requires 8 characters, so you're going to have to put Smith, comma, and as much of their first name as you can get in there in 8 characters. It's better not to put 0, 1, 2, 3, 4, 5, 6, 7, 8, because what happens when you dock that glucometer is it never makes it into the patient's record. If you put the patient's name, as much of the name as you can get, when that gets hung up in the system, somebody's going to go find out who is Mr. Smith and where do I need to put this glucometer result, and they'll get it into the computer for you. And if you have the FIN number, of course, you can type the FIN number in. That's even better. The glucometers really should live in the docks or the cradles because that charges the battery. It downloads the information from the glucometer into Cerner, and it will update any software that's pushed out through their system. Another little caveat, which I don't think happens very often, is just make sure that when you're testing, and I'm going to use my cell phone for this, that the glucometer is tilted down to get the sample, because if it's tilted upward and you put the sample up here, occasionally you'll get blood that runs down the strip and into the meter, which is not good because you can't clean it. So just a small caveat. That doesn't typically happen when you're doing finger sticks. It's usually going to happen when a nurse gets a blood sample from an art line and puts it on there. It can run down the strip, but just keep that in mind. And then also it's extremely, extremely important to disinfect the meter between patient rooms with 2 purple top wipes, 1 to clean it and 1 to disinfect it. And really the goal is to get that meter wet for 2 minutes to kill any bacteria. You don't want to take bacteria from one patient's room into the next. Okay, so let's talk a little bit about nutrition at mealtime. The goal, obviously, is to ensure adequate nutrition for healing while maintaining good blood sugar control. It's important to know that the average patient only eats 1,000 calories per day while they're in the hospital. So they are at greater risk of malnutrition. And that leads me to, can patients eat sugar? Absolutely. People with diabetes can eat sugar. A lot of times when people are ill, sugar is what they want. They want comfort food. And so what we do here at Ascension St. John is that carbohydrate will be counted in the total carbohydrate on each meal tray. And we'll talk a little bit more about what carbs are and how you can fit sugar into that meal plan. The best approach for glycemic control includes counting and being consistent with the amount of carbohydrates that we provide the patient at each meal. The nurses are going to be attempting to match the mealtime insulin to the amount of carbohydrate eaten. And then monitoring outside food and drinks brought in from family members. Totally okay to do. We just need to kind of prepare for it. The nurses are going to be trying to limit outside food to whatever the diet order is. So if they're on a 60-gram consistent carb diet, we don't want the patient's family bringing in 100 grams of carbs and the patient eating 100 grams, because we have dosed their insulin based on 60 grams. So the nurse needs to know if outside food is brought in so that they can kind of work through that with the patient. And another little tip, calorieking.com is a great place to look up food. If a family member brought in Wendy's, since it's so close here in Tulsa, you can literally look up a Wendy's hamburger and it will tell you exactly how many grams of carbs are in it. It's very quick and easy to do. And then ask the nurse if a diabetes education consult would be helpful for patients that are eating or drinking excessive carbohydrates and drinks. Sometimes it just takes an educator to come in and kind of explain to the patient why it's so important that we work together to maintain a consistent amount of carbs with their insulin dosing while they're in the hospital. So documentation of meals. Since nurses are giving insulin based on how well a patient eats, documenting PO intake is extremely important. We want to be as accurate as we can, and we want to consistently document it. A lot of times you'll look into a patient's record and you may have a few days of PO intake and then several days where it wasn't documented. So it's really important, especially for those people who are getting insulin, for the patient care tech to make sure that the PO intake percentages get entered into Cerner. That way the physician has that information, the dietitian has that information, the nurse has that. I mean, we're all working together. So that information is really important. I don't think that patient care techs probably realize a lot of times that we do use the information that you enter into the computer every day. So what is a carbohydrate? In our food that we eat every day, there are 3 main nutrients: carbohydrates, proteins, and fats. Carbohydrates are the foods that are going to affect a patient's blood sugar the most. And this is why we're counting grams of carbs on the meal trays, okay? And you can see in the little graph here, that dark bold line is the effect of eating a carb on your blood sugar. When compared to the dotted and dashed lines, that's protein and fat. You can tell it's much more blunted, doesn't have much effect on blood sugar, and hence the reason why we're counting carbs. So a carbohydrate is anything in the starch group, which would include breads, pasta, rice, crackers, chips, potatoes, corn, those starchy vegetables, beans, anything in the dairy or milk group, anything in the fruit group, so juice or fruit, and then of course anything with sugar on it. Those are all your carbohydrate foods. A lot of people say, oh my gosh, milk is a carb, it's bad, or I can't have fruit. That's not the case. We want you to count it as a carbohydrate, and we want to be consistent with it. Of course, milk and fruit are healthy choices, but when you have diabetes, you need to make sure that you're not overeating on carbs, because that will greatly affect their blood sugar. In fact, I had a patient one time say, well, I ate like 10 pears yesterday. We got a case of pears, and I ate like 10 of them. I'm like, this is why your blood sugar was 275. They didn't understand, it's a healthy food, so he didn't think twice about eating extra fruit that day. So what is not a carbohydrate? Anything in the protein or fat group is not going to be counted as a carbohydrate. So that would be things like meat, eggs, cheese. In terms of fats, like oils, salad dressing, cream cheese, nuts and seeds are actually fats. And then any free foods, things that have less than 5 grams of carbohydrate per serving would be free. Patients with diabetes love free foods because they can eat them basically and not worry that they're going to affect their blood sugar. And one perfect food that we have in the hospital that is a free food is sugar-free Jell-O. There is 0 grams of carbohydrate in that. And if the patient's hungry and their blood sugar is elevated, sugar-free Jell-O is the perfect snack. So consistent carbohydrates. I'm sure you're aware that we have 3 consistent carbohydrate meal orders within Cerner. We've got a 45 gram per meal, a 60 gram, and a 75 gram. The 60 is the default. So if the doctor doesn't choose the 45 or 75, they're going to get the 60 grams per meal. We need to also, when patients are hungry and wanting a snack, of course, we want to feed them. We don't want to tell them, no, you can't eat. But we want to make sure that those that have already eaten well, or those that have elevated blood sugars, that we're not making it worse by giving them high carb snacks. So here are a few ideas for low carb snacks for those that, their blood sugar may already be 250 and you don't really want it to go higher. A cheese stick, sugar-free Jell-O, diet soda, a broth would be fine. Or even if you can call the cafeteria or the dietary department and ask for a veggie tray with some dressing, they can eat on that and not worry that it's going to affect their blood sugar. The high carbohydrate snacks that we typically have on floor stock on the floors would include ice cream, sherbet, sugar-free pudding, regular soda, milk, and juices. So a lot of you are probably thinking, sugar-free pudding, why is that high carb? Well, the sugar-free pudding mix doesn't have any sugar in it, but you mix it with milk, which is a carb. So it's still about 15 grams of carbs for one of those little pudding packs. So if the patient's still hungry, a lot of times we'll have larger men, like 6 foot 220 men that are still hungry after their meal trays. Absolutely ask the nurse to consult the dietitian, because they can come and adjust what's coming up on their tray. They can double up on their protein, they can double up on their veggies, and still stay consistent with their carbohydrates. And then your patient doesn't complain about being hungry. So we need to work on hardwiring the mealtime process. And the reason being is we want to use timely and accurate fingerstick blood glucose results in order to dose insulin on. The other important aspect of this is timing. We want the nurse to give the insulin as soon or around the mealtime. So coordination of care between touch point and those who are bringing the trays up, nurses and the patient care techs, is extremely important. So what we have done is we've set up a kind of a process where dietary is, or I want to call them tray runners. I think they call them hosts or hostesses. But when the trays are leaving the kitchen, they are going to call the nursing unit and let them know, hey, the cart is leaving the kitchen. That gives the patient care techs the first warning, hey, the trays are on their way. It's time to go do my vitals and do my rounds and get blood sugars. The communication to the nursing team that trays are coming Each nursing unit may be different, just depending on the technology that they have. If shooting out a page, or I think you guys have things called zebras, some way to shoot out some communication that the trays are on the way is super important to whoever gets that phone call. Then you can start your vital rounds. And then once you've done your rounds, go immediately and let the nurse know what her blood sugars are. That way, if she needs to give the insulin before the meal, she can do so. Dietary then is also going to notify the nursing station once they get up to the unit, because some of the units, when the cart shows up, you don't even know that they're there because they're down the hall and it's not seen by the main nursing station. So they're going to come up front, let the unit secretary know that, hey, we're here, we're going to start delivering trays. And then again, whoever gets that information is going to communicate again, hey, the trays are here. Dietary is going to start passing the trays. When they pass the trays, if they get to a consistent carb diet, they're going to ask the patient, has your finger stick been done? Have they checked your blood sugar? If the patient says no, they're going to push the call light as a third notification to, hey, I'm dropping off the tray. Somebody needs to come check the blood sugar. And they're going to go ahead and pass the tray. That way, the nurse can administer insulin to the patient or hold off until immediately following the meal, if that patient's kind of iffy as to whether or not they're going to eat the whole meal. Patient care tech should make a second round to obtain the PO intake percentages and then immediately let the nurse know, hey, the patient ate 50%. That notifies her so she can adjust that insulin dose and go give it. Okay, diabetes devices in the hospital. So let's talk about insulin pump technology. I'm sure you guys have all seen insulin pumps and glucose sensors on patients coming in. So I just want to kind of review what pumps are, how they function, so that you can better take care of your patients. So basically, an insulin pump is a small device that holds insulin. It only uses rapid acting insulin. There's no long acting insulin in the pump. And it's going to drip all day long, drip, 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 just to maintain a stable blood sugar all day. And then the patient, when they eat, they're going to check their blood sugar and they're going to count their carbs on their tray and they're going to enter that information into the pump. The pump will then calculate, hey, you need this much insulin for the high blood sugar and this much insulin for the food that you're going to eat, and they hit another button and it delivers the bolus. You can wear an insulin pump and a glucose sensor independent of one another, meaning they're not communicating. But now there is new hybrid closed loop technology and automated insulin delivery devices that use the glucose sensor to adjust the insulin that's being given by the insulin pump. So those two devices, I don't want to say most, but a lot of patients are wearing this type of system nowadays because the pump is going to adjust based on what the blood sugar is coming from the glucose sensor. So they still need to enter, it's not a closed loop system in that you wear it and you don't have to put any information in. The patient still must enter how much carbohydrate they're eating and what their blood sugar is in order to bolus an extra amount for that meal. But just keep in mind, some of them are communicating. And like I mentioned earlier, those wearing insulin pumps are at high risk of DKA should they become disconnected or have an occluded or kinked cannula, the little plastic tube under the skin, interrupting insulin delivery. So just keep that in mind. So what do you need to do as the patient care tech? Your patient has an insulin pump. You definitely need to let the nurse know if the patient has told you, hey, I'm out of pump supplies or insulin, or oops, I forgot to bring my charging cable. A lot of the pumps nowadays charge using like a cell phone charger. So if they don't bring that charger in with their pump, there's not going to be any way to recharge it. So if you ever hear the patient say, I don't have enough pump supplies or I don't have insulin, that is super important. And so definitely share that information with the nurse. And then also patients are supposed to be documenting how much insulin they're bolusing at mealtime on that flow sheet that is at bedside. So just encourage or remind patients, hey, how much insulin did you take at lunch? Make sure that you're writing it down on the flow sheet. That gives us documentation so that the doctors, the diabetes educators, the dietitians, can better manage their care while they're here. And then obviously continue to monitor blood sugars with the hospital meter. A lot of people are now wearing continuous glucose monitors on their arms to check their blood sugar. And when they come into the hospital, their expectation is, hey, I've been doing this whole time with this sensor on my arm. I don't need you to poke my finger to check my blood sugar. That's false. Those CGM devices or glucose sensors are not FDA approved for treatment decisions in a hospital yet. That may change, but at this time they're not. And so we need to make sure that we're monitoring patient blood sugars with our hospital meter. Many reasons. Our meter is accurate and we know it. We do QCs on it every day. So that's important. Number two, the glucose sensor that the patient is wearing is actually using interstitial fluid to calculate what the blood sugar is. It's not using a blood sample from their finger, which is highly accurate. If they're using a glucose sensor, it will lag behind the finger stick about 10 minutes. So you may look at the sensor and it says, oh, my blood sugar is 85, but the patient's shaking and they feel like they're having a low. That's because the information that they're getting from that sensor is 10 minutes ago. Okay, so keep that in mind. A lot of patients don't understand that concept, and so they're questioning accuracy between our meter and their sensor. We shouldn't compare those two things because they're checking two different things. And then obviously don't let a patient disconnect from their pump for more than an hour. If you notice they took a shower and haven't hooked back up to their pump, just remind them to make sure to hook back up to their pump. And like I mentioned before, here's the information about continuous glucose monitors and to continue to use the hospital meter. The patient can still wear the sensor. That's one thing I didn't mention earlier. It's good for alarms. It will alarm if you're dropping too quick or rising too quick. And so it is nice for that. And the patient can use it for those things in the room. But we really need to continue to monitor with our meter. So managing hypoglycemia. Why in the world is this so important? It's because there's a 7% higher odd of in-hospital death for those that are having hypoglycemia in the hospital. And it's even worse if they are having severe hypoglycemia. 84% of patients with severe hypoglycemia had an episode of mild hypoglycemia during the same admission. So those that have already had a low blood sugar are at greater risk for having another one today, tomorrow, or the next day. So if you know the patient's had a low blood sugar, pay attention and watch them closer. Ordering the hypoglycemia protocol does reduce severe and recurrent hypoglycemia during the stay. And believe it or not, after hypoglycemic events, 75% of patients don't have an insulin dose adjustment by the provider. So they've gone low and the doctor has not backed off on their insulin. And that's something that I'm working with the providers to do a better job at. We're trying to get them to back off on how much insulin they're giving if the blood sugar for those on insulin has dropped below 100, hopefully preventing some low blood sugar. Those that are high risk, like I said before, those that have already had a hypoglycemia event, those with a history of diabetes, those older than 65 years of age, definitely people who are on insulin, which are most of our people with diabetes in the hospital, those with kidney disease, missed insulin doses, MPO status, or not eating well, or if they're on nutrition support and we had to hold it for any reason. So the Ascension glycemic control best practices, the physician needs to order the hypoglycemia protocol. That way you have, and the nurse has the protocol to address any blood sugars less than 70. We did update the critical glucose level to less than 54, and that's purely to get ahead of any severe lows. We don't want to wait until the blood sugar is below 40 for the lab to call us. So them calling a little sooner gives us the opportunity to get in there and treat it before they get severely low. There's also a big push with the new protocol to use medical carbohydrates. Rather than using juice, rather than using peanut butter and crackers and those kind of things, we're really pushing for the nurse to use glucose gel, the glucose liquid, and then some hospitals have implemented glucose tabs. I don't believe that we're going to do that here. You're going to either have the gel or the liquid. And then obviously the physician to follow up and to review after a hypoglycemia event to reevaluate, hey, are they not eating well? Do we need to adjust the diet? Should we decrease the insulin? All that good stuff. You can see the symptoms of hypoglycemia. You guys are probably well adept at knowing when your patient's having a low, but I will say that each patient is very different in terms of how they feel their lows. But these are the most common symptoms. So the American Diabetes Association came out in their literature suggesting we categorize blood sugars into 3 levels. A mild or level 1 would be 54 to 70, so it's just slightly below 70. Moderate, anything below 54, and then a clinical event, or the severe, level 3, would be a clinical event characterized by altered mental status or physical function that requires the assistance of someone else for recovery. So, high blood sugar. So there are opportunities at all of our hospitals to do a better job in terms of controlling high blood sugar. And so the best practice that Ascension has pushed out is obviously to monitor finger stick blood glucose as close to mealtime as possible, notify the nurse of the pre-meal finger sticks immediately so that they can time their insulin appropriately, documenting accurate PO intake percentages for all patients, and then let the nurse know how well the patients ate. And then following the diet order prescribed by the provider and limiting the carbohydrates in the diet based on that order. So hyperglycemia risk groups are very similar to the hypoglycemia risk groups, those with a history of diabetes, those that are older or elderly patients. And then certain medications can also cause hyperglycemia, including steroids are probably the biggest one. If we've missed or held insulin doses, or if we started TPN, it's got a lot of dextrose in it, so that too could cause high blood sugar. IV dextrose, extreme infection or stress, physical stress, can cause significant hyperglycemia. And then those that are, the doctor has only ordered a correction scale of insulin and not any long-acting insulin, those patients are also at risk. So monitoring for high blood sugar includes obviously the point of care glucose monitors are the current recommended method. And I can tell you that our glucose monitors that we're using, the stat strip, are the highest or carry the highest accuracy on the market. And so you can trust what's being said on those meters. And if it doesn't match, you can always recheck, but they are very accurate. And I think I mentioned this earlier, those people that are at high risk, obviously we need to be monitoring routinely. So let's talk about DKA and HHS. So we talked a little bit about DKA earlier, not so much HHS, which is called hyperosmolar hyperglycemic state or syndrome. They are the most serious and life-threatening hyperglycemic emergencies that can occur with people with diabetes and a leading cause of death for those. Just be aware and pay attention to your patients. If you notice that anybody's got increased thirst, increased urination, rapid breathing, nausea and vomiting, a fruity or acetone odor to their breath, or any kind of change in alertness, that is definitely a red flag. Especially for somebody who has diabetes, and you should let the nurse know immediately. So go ahead and scan the QR code here for attendance tracking. I'm going to leave it up here for a few seconds so you can scan it. And then we're going to move on to a quick little fun quiz. And if you don't get this scanned in time, I know that Caitlin will be able to send this out to all the nurse managers so they've got it so you can scan it. Okay, so let's do a fun quiz. Probably the easiest way is either to take yourself off mute or type your answer in the chat box. Okay, so first we want to match the types of diabetes. Let me know what you think best matches type 1 diabetes.
The second one is going to be type 1.
Yes, type 1, but you've got 3 boxes. It's either diagnosed during pregnancy.
That's gestational.
Good for you. Bonus points. Commonly occurs in youth, but can occur at any age. It's an autoimmune disease, requires insulin for life.
Type 1.
Yeah, you're right, type 1. Or can occur at any age, but most commonly later in life, caused by insulin resistance. That would be type what?
2.
Type 2. Bonus points for you. Okay, next question. What affects blood glucose levels the most? Is it carbohydrates, proteins, fats, or not eating? Kylie says A, carbs. Stacy Garrett said A, carbs. Yes, you're correct. It's carbohydrates. That affects the blood sugar the most. So are the following foods a carbohydrate, protein, or fat? Let's start with bread. Carb. Ashley's right. So is Kylie. How about olive oil? Fat. You're right. What about an apple? Yep. Carbs. How about butter? Yep. It's a fat. Eggs. Yep. You guys are good at this. Protein for eggs. What about rice and bananas? Carbs. You're right. And steak. Carbohydrate, protein, or fat? Protein. You're right. Beans. So black beans, navy beans, any kind of beans. I knew we would get some disagreement on this one because it is both a carb and a protein. So Autumn, you're correct, because for diabetes, we're going to count it as a carb because it has a ton of carbs in it. However, it also has protein. So Lily and Alyssa, you're both right. But for people with diabetes, we're going to count beans as a carb. And then finally, nuts or seeds. Carb, protein, or fat. It's a tricky one. A lot of people don't realize. It is actually a fat. Okay, next question. The order for fingerstick blood glucose monitoring is AC and HS. The evening meals arrive to your unit between 1800 and 1830. What time should you check the patient's blood glucose? Is it A, any time between 1700 and 1800? Once dietary notifies the floor the meal cart's on its way, after meal delivery and the patient has eaten, or any time after 1500? Remember that we want to hardwire what we're doing, and we walk through the steps on when to do.
Is it B?
It is B. You're right, and Stacy got it also. You're going to wait until the dietary department notifies your floor that the cart has left the kitchen. It's on its way up. Okay, that ensures that the nurse is going to dose insulin based on the most current blood sugar reading. If it's over an hour old, you're going to have to get another finger stick. So, okay, so this one has a fill in the blank and 2 answers. Hypoglycemia or low blood glucose is considered blood glucose levels less than blank, and the critical glucose level is blank. So your options are 70 and 54, 80 and 40, 150, or 60 and 40. Yep, you guys that are putting it in the chat, you're 100% right. It is, oops, I forgot to give you that answer. It is 70 and 54. So hypoglycemia is anything less than 70, and the critical glucose level is less than 54. Okay, this may be our last one. Mr. Jones has a history of type 2 diabetes. When you enter his room, Mr. Jones looks sweaty and is slow to answer your questions. You check his blood glucose and it's 62. What do you do? Do you give Mr. Jones a juice and tell the nurse? Do you immediately tell the nurse? Do you give peanut butter and crackers and check on him in an hour? Do you give him a tube of glucose gel and recheck blood sugar in 15 minutes? That's kind of a trick question.
B.
B, immediately tell the nurse. You're right. You're right. Now, D is not incorrect, but the nurse needs to be the one that's directing that care. So yes, D is correct for the nurse to do, but you need to immediately tell the nurse. Okay, at lunch, Mr. Jones's family brings in a Wendy's Frosty and a hamburger for him to eat. What should you do? A, nothing. He hasn't been eating very well. Let him eat it. No, or B, notify the nurse who can look up how many carbohydrates are in the Wendy's food and allow him to consume the amount equal to what his diet order states. C, tell the family that he has to eat what comes on his meal tray. Or D, tell the patient he can't eat sugar because he has diabetes. Caitlin got it right. It is B. Let the nurse know. She can look up the carbs and tell, you know, I can tell you just from personal experience, a Wendy's Frosty is going to be about 60 grams of carbs, which is the total amount of his carbs on the tray probably. So he may have some choices to make on that one. Oh, I thought we were almost done. It's 10:30 and your work is caught up. To better prepare for lunchtime, you start your rounds for vitals. Why is this not a good idea? A, your finger stick blood glucose will be done too early and the nurse will need to repeat it in order to use it to give insulin. B, the dietary tray runner has not called the unit to notify you the trays are on their way yet. C, it's always good to work ahead when you have the time. Or D, both A and B. Yep, Cheryl got it. It's D. True or false? You should wait until dietary notifies the floor that the trays are on their way. True. We kind of hit that just a minute ago. Does anybody have any questions or comments that I can answer before we hop off? I'm going to go back to the QR code in case anybody missed it. If you have any questions, either you can come off mute. Oops. May have to get out of here. Any questions? As long as you've scanned the QR code, you're good to go. Thank you guys for hopping on this morning. And if you ever have any questions, you can always ask your diabetes educators on the floor, or feel free to call our Healthy Lifestyles department and you'll get one of us. Thank you guys.